Welcome to This Explainer. Look, if you're an emergency physician, an acute care clinician, or just a focused learner who's really fascinated by high-stakes medicine, you are absolutely in the right place today. We're going to unpack a true medical detective story. We're talking about the diagnosis and management of acquired hemophilia. We're going to dig into the untold history of this condition and, more importantly, give you the rapid, actionable clinical pathways you're going to need when every single second counts.
Okay, let's dive right into this. Picture this terrifying reality: a sudden, massive, and largely unexplained subcutaneous hemorrhage in an elderly patient. Imagine this patient is rolling through your ER doors right now. They're bleeding profusely, and their vitals are just starting to drift.
The absolute first question you have to ask yourself is this: why is an elderly patient who has literally zero prior history of trauma and no personal or family history of a bleeding disorder suddenly bleeding to death, right? This is the gripping clinical mystery of acquired hemophilia. It's a presentation that demands your immediate, undivided attention, because honestly, if you miss it, the patient could very easily lose their life.
So here's our roadmap for the explainer. 1. The untold history. 2. Risk factors and presentation. 3. Diagnosis in the ER. 4. Acute bleeding management. 5. Outcome and disposition. And 6. We'll wrap up with a summary and key messages.
Starting with Section 1, the untold history, the autoimmune saboteur. 78 years. According to the largest observational data sets out there, this is the median age of presentation for this disease. I really want you to anchor this number in your mind. Now, sure, this can happen to younger people, specifically postpartum women, but generally speaking, this is primarily a critical condition of the elderly.
So, the crucial point is understanding what exactly this disease even is. Acquired hemophilia A, or AHA, is not some genetic defect you're born with. It's actually a rare autoimmune disorder. Basically, your patient's immune system has just suddenly gone rogue. It starts producing immunoglobulin G autoantibodies that specifically bind to and neutralize factor VIII. And, well, without factor VIII, the entire coagulation cascade fails and the patient starts bleeding uncontrollably. It is a sudden, unprovoked autoimmune attack.
Moving on to Section 2, risk factors and presentation, cracking the phenotype.
You know, acquired hemophilia is distinctly different from the congenital hemophilia you probably learned all about in medical school. Congenital hemophilia classically shows up in young males with a family history, and the absolute hallmark sign is bleeding into the joints. But acquired hemophilia, it's kind of the exact opposite. The bleeding usually shows up as these sudden, massive subcutaneous hematomas, extensive bruising, or mucosal bleeding. And again, it's mostly in elderly patients or postpartum women. Joint bleeds are actually incredibly rare here.
So, what actually pulls the trigger on this autoimmune saboteur? Bizarrely, about 50% of the time, it's completely idiopathic. It's just terrifyingly random. But the other half of the time, we do find an underlying trigger. It might be another autoimmune disease like lupus or rheumatoid arthritis. It could be a solid or hematologic malignancy. Sometimes it's even triggered by everyday medications like penicillin. And, as we mentioned, in about 10% of cases, it hits women during the postpartum period.
All right, Section 3, diagnosis in the ER, the clinical detective algorithm.
Let's move to and see how this builds step by step. Here is your rock-solid diagnostic pathway. Step 1 is your biggest clue. You find an isolated, prolonged APTT while the PT and platelet count stay totally normal. Step 2, you do an APTT mixing study. Now, because an inhibitor is present, the patient's plasma will not correct when you mix it with normal plasma. Step 3, you measure factor VIII activity, which is going to be significantly reduced. And finally, Step 4, quantify that inhibitor titer using a Bethesda assay.
I want to pause right here for a second because this is one of the most absolutely crucial clinical pearls of this whole explainer. An unexplained APTT prolongation in the ER, especially if it's right before an invasive procedure or it's coupled with bleeding, must never be ignored. Please do not just write it off as a lab error. Don't just assume, oh, it's probably just a lupus anticoagulant without actual proof. Dismissing this prolonged APTT can quite literally lead to fatal outcomes.
Section 4, acute bleeding management, the rescue.
Listen to this mandate directly from the international recommendations. It says, hemostatic treatment should be initiated in patients with AHA and clinically relevant bleeding, irrespective of inhibitor titer and residual F8 activity. Okay, so what does that actually mean for you down in the ER? It means you do not sit around waiting for those Bethesda assay results to come back from the lab. If your patient has suspected acquired hemophilia and they are actively bleeding, waiting for that titer can be a fatal mistake. You have to treat them immediately. So, what tools are in your toolbox to treat them?
Well, since their body is actively destroying human factor VIII, giving them standard human factor VIII usually isn't going to work. Instead, we have to use bypassing agents or modified factors. You can grab recombinant factor VIIa, usually starting at 90 micrograms per kilogram. You could use APCC, which you probably know as FABA. That's a plasma-derived prothrombin complex. Or you can use recombinant porcine factor VIII. This one often manages to escape those human autoantibodies, though you do have to monitor their factor VIII activity pretty closely if you use it.
And this brilliantly illustrates how we actually choose between these options. Your decision tree really relies heavily on what your specific center has available. Whether you've got recombinant porcine factor VIII on hand or a bypassing agent like RFVAI, the rule is you start your first-line treatment right away. Then, you watch their clinical response like a hawk. If the bleeding doesn't stabilize, you rapidly pivot and switch to an alternate first-line agent. The real secret here is having this mental algorithm mapped out in your head way before a bleeding patient ever rolls through your doors.
The MASAC guidelines also lay out some super crucial operational rules for the ER to prevent iatrogenic harm. First, triage these patients urgently. Factor replacement must be available within 1 hour of arrival. Second, use the smallest gauge needles possible for IV access. Third, absolutely no intramuscular injections, none. And here is a massive one: avoid fasciotomies for intramuscular bleeds. I can't stress this enough. Surgical intervention here can trigger catastrophic, uncontrolled bleeding. Early hemostatic therapy is the correct way to reverse developing compartment syndrome in these cases.
Section 5. Outcome and disposition beyond the ER.
Greater than 40%. That is a heavy number. If the diagnosis of acquired hemophilia is delayed, or if your initial treatment is inadequate, the mortality rate can easily exceed 40%. This is exactly why your rapid recognition and treatment down in the ER is literally the single most defining factor in whether this patient survives or not.
Ultimately, management here is a two-pronged parallel approach. In the emergency department, your job is prong 1. Get that acute bleeding under control with bypassing agents. But remember, the patient is not cured until prong 2 is complete. Hematology has to step in next to eradicate the inhibitor using immunosuppressive therapy. They'll typically rely on heavy hitters like corticosteroids, rituximab, or cyclophosphamide. It's a complete team effort, but you are the vital first responder that makes it all possible.
Section 6. Summary and key messages, your clinical pearls.
Okay, if you take absolutely nothing else away from this explainer today, please memorize these 4 points. First, sudden massive bruising in an elderly patient with no trauma is acquired hemophilia A until proven otherwise. Second, an isolated APTT prolongation is your biggest lab clue, and remember, it will not correct on a mixing study. Third, treat clinically relevant bleeds immediately using bypassing agents like RFVIA or APCC. And fourth, I'll say it again, never ever wait for the Bethesda inhibitor titer to come back before you start saving that patient's life.
I'm going to leave you with this provocative thought. The next time you see an unexplained, isolated APTT prolongation on your shift, and you're surrounded by all the usual chaos of a busy ER, are you going to just dismiss it as a simple lab error? Or are you going to put the pieces together, catch this autoimmune saboteur, and save a life before it is simply too late? Thank you so much for joining me for this explainer, and hey, stay curious out there.